Without further ado, let me introduce Dr. Robin Schoenthaler. She's a board-certified radiation oncology, and she received her medical degree from the UCLA School of Medicine, and she did her residency in radiation oncology at the University of California in San Francisco. She completed a fellowship in charged particle radiotherapy with Dr. Joseph Castro at the Lawrence Berkeley Laboratory. And then she joined the Department of Radiation Oncology at MGH in 1982. In addition to her illustrious medical career, she's a multifaceted, talented woman. She has won multiple awards as an essayist, particularly in the field of medical memoir, and she's had numerous lay articles published in the national press. In the last few years, she's become increasingly involved in storytelling, and last year she won the Boston's Mother Grand Slam at the Cutler Theater. In addition, she is the mother of two young adult men who are spectacular. Kenzie, who recently graduated from Lesley University with a degree in biology, and now he works in cancer clinical trials. And Cooper, who is studying finance and entrepreneurship at Northeastern. She's obsessed with COVID, and as part of the history of epidemics, she studied in medical school. We are thrilled to host this event with you, Robin, and we're thrilled that you're sharing your expertise with us. So without further ado, Maddie's gonna man the chat box and I'm gonna disappear. We're gonna let Robin go.
Okay, that's an absolutely lovely introduction. And I appreciate it very much. I really appreciate the opportunity to be able to talk to you guys because I really wanna sort of spread the gospel of COVID in a way that's understandable and science-based. So thank you all for letting me do this. Thank you guys that are in the Zoom audience for wanting to do this, for taking time out of your busy days, basically for wanting the world to be a better place, and most of all, for being willing to do another Zoom call. I know that most of us spend our days pretty much in this position, and it's very heartwarming to me that people are willing to spend another hour or so in whatever Zoom position you end up in. So thanks, Margaret and everybody at the Healing Garden for letting me do this. As she mentioned, I do have two adorable children who are now socially distancing in the Boston area, all grown up and trying to be safe. I think some people are probably asking, how did she get here? Why do we have a radiation oncologist of all things talking about COVID? And I will tell you that basically it started out one night in March with a glass of red wine, when I wrote an email list to the Arlington town list where I live, which it was basically a howl in the darkness. It was March 6th. It was a week before we got shut down here, but I was so frantic about what I was hearing about in New York and in Italy that what I knew about the history of epidemics, that I sent out an email that said, I'm here to tell you that we're facing a major life-altering epidemic, and that our lives are going to be changed for a long while, as it turned out. And that older adults, I was very worried that older adults needed to start staying home, even if the government hadn't told us that. So that was March 6th. This last week, I wrote my 35th weekly essay on COVID. It's like 44,000 words. It's kind of crazy. And they're seen by, they figure about 100,000 people a week. I do come to this with the absolute disclaimer that I'm not an infectious disease specialist. I'm not working on the front lines. I'm not a virologist. I don't study epidemiology. And I'm not an aerosolologist, which I didn't even know the field existed. But I'm here to tell you, I don't know anything about HVAC, okay? But what I am, as Meg mentioned, is I'm a longtime student of epidemics. And that's because my medical training, my medical experience in the very early days of my medical education was completely consumed and bookended by AIDS and HIV. And I think that's one of the reasons that I've been consumed by COVID from the start, from the very earliest of days. I just want to compare and contrast the HIV timeline just for a minute. First off, you'll, my my cursor is not working. Way over on the left is when I started being involved in medicine, and that was when we were very first starting to see gay guys be very sick. The last arrow in the middle of the screen right before 1992 is when I came to Boston and stopped working with AIDS patients. But in the meantime, I had started medical school in 83, which they didn't even know that it was HIV. They didn't find the HIV virus. They knew about AIDS, but they didn't know the HIV virus existed till 85. That's that little arrow. And they didn't come up with a blood test for it till 87. So I started out med school not knowing that there was a virus. It took until 1980, an entire medical school education of time to figure out the test. And I know when they invented the test in 1987, because that was the year that I got a really bad needle stick from an AIDS patient. I had to have the test 3 times. So I can tell you all about that test. In counterpoint, with SARS-CoV-2, the virus that causes COVID, in December 30th, they first found the specimens that enabled them to identify that it was this new coronavirus. And that was on December 30th. On January 20th, they had the genome sequence. I mean, the science of corona is just orders of magnitude different than it was with HIV and even with Ebola or any of the more recent outbreaks. So here you have HIV took 4 years to come up of my entire education to come up with a test. And here you have 10 days to come up with the whole entire genome. It's like unbelievable. So just for a second, the reason that I ended up writing, beside the fact that I was becoming increasingly consumed with the knowledge, was that it turned out that my friends were just absolutely desperate for straightforward information. And I'm a doctor, I like to teach. So it was helpful for me to be able to synthesize the information, give it out to people. But it also turned out that it was really good for me. And I highly recommend it. I highly recommend spending time learning about the science of COVID. Because what happens is that you're hanging out with people that are problem solving, as opposed to the media, which are problem listing. So I spend my days when I'm free, listening to podcasts like This Week in Virology, where these old geezers that have been doing podcasts for years are now rock stars. MedCram, where in 15 minutes you can learn all about a subject. Grand Rounds on the East Coast and the West Coast, incredibly interesting. Look at that, run by all women. Isn't that cute? Isn't that cool? Not that way when I was in med school, but it sure is now. And out here, all of these things are on YouTube. They're all accessible. You just search on YouTube for COVID Grand Rounds and boom, you can watch 5 of them a week. Also on the internet, there's great things on Facebook. This is Dear Pandemic, which is basically like Dear Abby, written by nerdy girls, PhDs and MDs who basically answer questions like Dear Abby about COVID, or really fantastic young women who are super boarded, super smart, super well branded, and write brilliantly about COVID. What it has ended up for me is just reinforcing my absolute bedrock optimism about science and the fundamental concept that no matter what we're going through right now, all epidemics always end. So just getting into the science briefly here. All this trouble is caused by this incredibly simple organism. This is SARS-CoV-2. It's basically a glob of fat, a round little ball of fat that has some little protein sticking out of it. And inside of it, it has mRNA, which is genetic material. That's all it has. Now, this is in comparison to like a bacteria, which is, on the other hand, incredibly complex. It's got tails, it's got front things, it's got all kinds of things inside of us. All our stupid little SARS-CoV-2 has this genetic material and the capability to hook into some of our cells, get inside our cells and reproduce there. The bacteria can reproduce itself. This one actually needs our cells to get into it to reproduce. And it causes all this trouble, including all this psychosocial trouble with our families where, for instance, this is sarcasm, just for those of you who don't know The Onion. Mom completely understands that coming over to Thanksgiving is risky and that you don't love her, right? Haven't we heard this? Aren't we dealing with this? Well, now we can explain to Mom why going to having a big Thanksgiving is not a good idea for 2020. As you guys know, if you've had any ounce of news on, Massachusetts cases are rising really quite precipitously. We know this both from the cases and also from our poop water. This is the wastewater that's tested at Deer Island. And they found it to be a tremendously accurate reflection of what's going on, is how many viral pieces of genetic material we're pooping out is reflected in this graph. And as you can see, it's going up. And it absolutely parallels the disease process that we see in the cities. In addition, this is a very scary graph that we're now up to 10% of people being positive who are being tested for the first time. So this is not all the college students that are being tested 2 or 3 times a week. This is not all the people that are being tested for work. These are people that are symptomatic or getting tested for travel, have a 10% positive rate. So you need to keep that in mind, that when you walk around, we may be up to, in some places, we are up to 1 in 10 people that you walk by may have COVID. This is also happening in the world. This is a couple days old. It's already out of date. In the United States, I made this graph on Sunday, and there was 11 million cases in the United States. Last night, there was 11.5 million. There was 500,000 cases documented overnight. So we're really in a bad, bad place. If I'd given this talk to you in July, I'd be like, oh, it's okay. It's not okay right now. We're in a bad surge. It's reflected in excess weekly deaths, and it's reflected in weekly deaths, where COVID during its bad phases absolutely outstrips all other deaths that we're seeing in the United States. Absolutely terrible, more than heart disease, more than cancer during its bad weeks. And it's bad in terms of history. So this is from October 26th, where you can see that the death number in the United States was 225. It's already, as you saw in the last slide, at 250. So the slide's already hopelessly out of date. And it's already outweighed the impact, no matter how you look at it, numbers or percentage of the population, of all the other flu epidemics we've ever had, with the exception of 1918. And now it's starting to outweigh most of the wars. And it's not just older people. Periodically, I'm going to include little myths. COVID is not just a disease of older people. Every single day in Massachusetts, we have a few people, young people, which I define as under 50, dying of COVID. So young people get it, young people get hospitalized for it, and they die of it. Not nearly at the rates of older people, but it definitely happens. I want to just talk for a minute about clusters in Massachusetts, because some people think, oh, if we hadn't had Biogen, we wouldn't have had such a bad spring. And it's absolutely true. Biogen was probably responsible for, at the last time of the most recent study, is probably responsible for 20,000 cases out of then like 120,000. All over the state and all over the world. And it's encouraging to think that during this winter, we won't have a Biogen. We're not going to have some big convention where a bunch of people end up infecting a lot of people in Massachusetts. But we've continued to have, sorry, this is not that great of a slide, but this just shows that we've continued to have little clusters in jails and in long-term care facilities. We have not had big clusters in colleges. I think the colleges in Massachusetts, especially around Boston, have just done a spectacular job at keeping the kids and the faculty safe. So there's not been there's been cases, but not out of proportion. But the scary thing about right now is that we're about to face a very scary cluster. We're not going to have Biogen. We're not having big outbreaks in colleges, and the jails are getting better. But we know this graph shows that everything on the right that's in red is a bad thing to do. It's a dangerous thing to do. And that's restaurants, bars, and coffee shops, basically eating inside, narrowly trailed by gyms and possibly churches, depending on their setups. So we know that it's dangerous to eat inside. But what are we all thinking about doing next week? Eating inside. So what I'm going to do is talk to you about the science for why I think we should not. Basically, I've come to the conclusion that people should not have large Thanksgivings. And I'm just going to show you the science for why I think this is true. And I feel the same way about Christmas and Hanukkah and everything for the next couple of months. So the question is, how do you get COVID in your mouth and nose? How did it happen at Biogen that all these people got it? Well, there were people that weren't wearing masks. They were sitting in crowded places, conference rooms, bars, restaurants. They were hanging out all day and all night. They had the windows closed because it was, February, inside because it was February. and they were hanging with people that traveled. So what do you do for Thanksgiving? All those things. It's what I call the illustrated children's guide to a super spreader event, to have a big Thanksgiving at your house. Because how does COVID spread? Well, we all know that it spreads from the respiratory system, which is basically your lungs, your mouth, and your nose. You can think about it in terms of glitter, right? How easy is it to get glitter all over your craft project if only one person is using glitter? It's exactly the same with COVID. Now, this is an important differentiation between other kinds of bugs, where, remember, AIDS came from blood or body secretion. So you had to be really careful about that. And some diseases come from water, and some diseases come from mosquitoes. This one comes from mouths and noses. And so that's what we need to be careful about. It comes from mouths and noses of an infected person on the left to an uninfected person on the right, a person that's never seen COVID and so doesn't have any antibodies. And that is like the hugest way that it happens, through droplets from one mouth to another mouth. There's some aerosols that hang around that have it, but basically it's the virus, live viral particles coming from the infected person's mouth into the mouth of the other person. Occasionally, you can have what's called fomite or environmental spread, but not that much. Not much at all. The lion's share is mouth to mouth, nose to nose. It's not the surfaces that you touch. At the beginning, we thought it was this, and so again, just to extend on that a little bit, breathing spreads droplets, a few. Talking spreads droplets more. Coughing more, sneezing more, and as we all know, even singing can cause droplets and aerosols to be spread. And we know this from that terrible poor church group in Washington, the state of Washington, where they sang and most of the people got infected and one poor person actually died. So if this is how it spreads, mouth to mouth, talking, sneezing, breathing, why was there such a big deal about fomites, about environmental stuff? Why did everybody wash their mail and refrigerate their canned baked beans and not use the toilet paper until it was out in the garage for a week? The reason that happened, the reason is because there was some early science that was somewhat misguided, in that what they did was they either took gobs of COVID and put it on surfaces and measured it to see how long it lasted. And what they were testing for was that genetic material. Or they tested areas around a person. And again, they were testing for that genetic material that's inside that little gold chain, but they were not testing for live infectious particles. So yes, it is true that the genetic material of the bugs can last on these surfaces, but it is not true that you will not get infected from genetic material. You need to have a whole big live glob of fat with the proteins and the genetic material inside of it. And that stuff all disappears easily with cleaning, with hand washing, with time, with sunlight. It all goes away. So it's turned out that this is how the testing is done. And again, we're looking for the genetic material. It turns out that fomites, environmental things, surfaces are not nearly as important as we thought. And they pale in comparison to the importance of protecting yourself from getting it from the mouth and nose. The other thing that I just want to emphasize right here, just for a second, I'm not going to talk about schools because it's way beyond my pay grade, but I just want to say that kids' spread is different, and that kids can have a lot of virus in their nose. And some studies have shown that they have a ton of virus in their nose, but they don't seem to spread it, especially kids under 10, nearly as much as adults. And that's because the disease is a little different in them. It seems that most kids tend not to have much in the way of cough or runny nose. They're not like spitting out all those secretions that they do when they have regular colds. They're having more like headache, fever, body aches. And so it appears that they do not spread it as much. And when they do, it tends to be at home with longer contact than at schools. And the other thing that I just want to say about kids is I just want to put it in context. Kids are our hearts, kids are our reason for living. And so it totally freaks us out to think about the kids getting sick. But the reality is that we're incredibly lucky with COVID. Kids are not getting super sick, hardly at all. They're 1%, they're 11% of all the cases if you call kids 0 to 18. Depends how you define kid, and they're only 2% of all hospitalizations, and usually around 1% of kids who get it get hospitalized. And in the whole country, as of last week, only, and this is not to say only, but only 121 kids had died of this terrible disease. In 16 states, none had. Now, this is not to say that this is even slightly acceptable. There's no kid, I heard a great thing, no kid is a numerator. And it's a totally tragic thing, but what it just puts into context is that it's extremely unlikely that our children are going to, they may get this, but it's very unlikely that they're going to get hospitalized. It's very unlikely that they're going to get seriously ill. And it's extremely, vanishingly unlikely that they're going to die, that our children are going to die of it. Just briefly, I want to go over the symptoms. There is really no way to be sure that what you have is COVID versus a cold, but there are some symptoms that happen with COVID that are a little bit different. Not that you can point your finger and say that's it, but you can have a higher level of suspicion. So about 40% of people, of adults have fever with COVID, and pulmonary symptoms, respiratory symptoms, dry cough, chest pain, difficulty breathing, and headaches, body aches, that sort of thing. Not much runny nose, although some, not much sneezing, although you can, excuse me. But there's some other things. This is how we definitely knew it was in China. But in the United States, we're seeing a lot more of this, of GI symptoms, a lot more of sore throat, and this really interesting loss of smell and sometimes taste, but definitely smell. And this is one thing where if it happens, you can be a lot more sure that it's COVID. I mean, not 100%, you gotta have a COVID test, but it's pretty rare to get a loss of smell with other viruses, whereas it's incredibly common with this one. So loss of smell really gets you going. And the GI symptoms can kind of fool you because you're like, oh, I think I ate something bad, or I have a tummy flu. So in this day and age, you should go get tested. The other thing that I've heard about a lot, it's pretty rare, but I've heard about it a lot, but nobody else I know has. So I thought I'd share it, is COVID toes, which is this very interesting thing where you basically wake up and you've got these changes to your toes. Sometimes they're very painful. It's not an infection. It's not a blood clot. They don't know what it is, but it too, like loss of smell, is almost what we call pathognomonic, where it's, almost definitely means that it's COVID. This goes away on its own, usually no complications. So what I want to emphasize here is that even though the symptoms, I do want to emphasize that for most people, the symptoms are mild or none. 40% of people have no symptoms when they're contagious. Many people stay without symptoms throughout their whole illness. And only about 5% of people end up in an ICU, but still, you don't want to end up in the hospital. That's more like 15%. Nobody wants to get this, and we don't know much about the long term. You don't want to get it. So how do you keep it from coming in to your mouth and nose? Well, we know this. This is boring. You've heard this a million times. Mask, distance, shorter duration of time with people, ventilation, hand washing, being outside, and not hanging out with sick people, which starts with don't go to work sick. Anybody that has any symptoms nowadays, stay home. No matter what, stay home if you possibly can, because then you're a super spreader. So we know all this. All of this is science-based. All of this has been demonstrated through science. So I'll get into a little bit. What has not been demonstrated by science is that mouthwash can kill coronavirus, and neither lamentably can wine. That's that picture. Isn't that sad? They tested it, but it turns out no, wine doesn't help. The best way to prevent it from coming into our mouths and noses is to do all of these things. And this is a really nice slide sort of showing the Swiss cheese theory of, okay, so what if it gets through, you're not quite far enough away from somebody, but you are wearing a mask and you are hand washing and you are whatever those other things say. I can't read it without my glasses. But anyway, multiple things keep you multiply, what I call safer, safe with a capital R. I'll show you that in a minute, not wine. So masks, I wanted to just have this picture because it's from this fantastic Instagram website or whatever it's called COVID Art Museum, because our artists are doing great art in the middle of all this, which always happens in epidemics. So what about masks? They've been absolutely demonstrated to work, just like pants are meant to keep you from spreading urine. If you pee on somebody and you're not wearing pants, they're going to get wetter. If you pee on somebody and they are wearing pants, i.e. a mask, they won't get quite as wet. If you're wearing pants, they will hardly get wet at all. It's exactly the same theory for masks. And this has been demonstrated over and over and over again that one person wearing a mask is a good thing, is a kind of good thing. Two people wearing a mask is a fantastic thing. Of course, you have to wear it right? The nose is connected to the lungs. Mouth is connected to the lungs. Nobody's helped by a chin mask. But the one thing you don't have to worry about is that you're not going to become hypoxic or have your oxygen levels go down by wearing a mask. That doesn't happen. This has been proven again, over and over and over again. What's the best kind of mask? Well, the best kind of mask is the kind that physicians have been wearing for years, right? To protect themselves from tuberculosis and a host of other respiratory diseases, and that's an N95. Second best is a surgical mask, 2-layer cotton masks, and the list goes on. I do want to emphasize that cloth needs to be thick. It needs to have at least 2 layers, a high thread count, fine weave, water resistant, cotton blends are better. You can read all about it in the internet, but basically it can't just be, the bandana that you pulled out of your camping trip. The 6 feet of distancing, just in case anybody wants to know how long that is, Amazon is selling this baton whose apparently only purpose is to be able to click it and see exactly how far away 6 feet is. But basically 6 feet is a good enough distance. 12 feet is a little bit better, but not a lot. 3 feet is less good than 6, but they're all, the whole purpose of all of that is for less droplets, less aerosols to be able to get close to you. And why does that work? Just the same way that it works with mold and oranges, right? I think this is a great graphic for, the further we all know this. If we separate our oranges, they won't necessarily get contaminated by the mold that we're seeing here. And of course, hand washing to the alphabet song or whatever playlist you put together for hand washing, which a lot of doctors have done, is incredibly protective to keep it away from your mouth and nose. So we know this, we know all of these things help. So I just want to talk about why they're so important to use all the time. And that's basically because with this virus, as opposed to others, we have a long period of being contagious while we don't have symptoms. So you and I are walking around together and we're completely clueless. We feel absolutely normal, but we're in fact infected and we're passing this on. And so you can see in the left part of the graph how contagious you can be, and then how sick you feel on the right can really be delayed. So you can have this terrible 2, 3, 4 day period where you're contaminating people absolutely unknowingly. With testing, we're testing for the genetic material. And here you can see in this graph that on the left, you're seeing how from the bottom part of the graph is where you've had the exposure. And then you have several days in the low part of the graph, I sure wish where your numbers of particles in your nose are really quite low. And that's when you can get false negatives early on, is because the number of particles are simply not enough to register in the test. This is on the blue, it's the PCR, it's the virus test. On the right, on the red on the right side is the antibodies, which I'm not going to talk about because it gets too complicated. But the bottom line is Jane can be exposed to COVID-19 on day 0, get tested on day 3 or day 5 and be negative, but in fact turn positive on day 10. And that whole time, if she hasn't been staying home, she's contagious and has been exposing her friends and families. And the reason that she's negative on day 5 is simply because the virus hadn't grown enough to be able to have the number of particles register on the test. So I write a lot about Uncle Maskless because we all have an Uncle Maskless in our lives, right? So he sits next to his nephew who's tested because he works in a restaurant and finds out the next day he's positive. So the question is that an exposure? And the answer is yes. An exposure is anything greater than 15 minutes in 24 hours where you're less than 6 hours away from people. And that's with or without a mask. All right. So when should Uncle Maskless go get tested? So what is he now? His nephew is the primary. His Uncle Maskless is the primary exposure. He's been exposed, and so he needs to go get tested, and he needs to go and stay home. He's had an exposure, a real exposure, less than 6 feet, more than 15 minutes. He's had a real exposure to a person who is positive. So he is now a primary exposure. He needs to go get tested, and he needs to quarantine for 14 days. All right. Uncle Maskless goes home to his wife, Aunt Petunia, and she is a secondary exposure. She doesn't need to get tested, but she needs to be careful. All right. So when should he get tested? Again, I just want to remind you, you don't want to sit next to your nephew on Sunday night, find out he's positive on Monday, and go to the doctor on Tuesday. Tuesday is too early. You need to wait at least 5 days to be able to get an accurate, to be able to have that number. See that number of viral particles go up high enough to be able to detect it. Okay, so just think day 5. All right. This is a great little graph from MIT. You can look it up. Basically, it's the same thing. If I've been in close contact with someone who's tested positive for COVID-19, I need to get tested. If I am in close contact with somebody who just tells me that they have symptoms, it's like, oh my God, thanks a lot, go get tested. All right. If I'm in contact with somebody who might have been exposed, I don't have to yet get tested. Wait till you find out if they're positive. Okay. And it goes on and on. There's all kinds of parameters. I like to remind people that doctors are not superhuman. We have great memories, but most of it we cheat. And the rules for how often how long you need to stay home depend on whether you have infection, in which case you go into isolation. You know, they both start with an I. That's how we remember it. That's how our cheating memories help us. If you're infected, you go into isolation for 10 days until the symptoms, or 24 hours after the symptoms are done. But basically it's 10 days because the assumption is you've already had the virus for a few days before that. If you just have an exposure, you actually go into quarantine for longer than that, for 14 days, because the incubation period is 14 days. So infection is 10 days, exposure with a quarantine is 14 days. What do you do if you're positive? If you find out you're positive, you consider, even if you're not sick, even if you don't have any symptoms, you need to consider yourself infected by the virus and infectious. You are contagious for at least 10 days. So you need to go home for 10 days. You need to tell your contacts because you're the primary person, but now they have had a primary exposure to you if it's been more than 15 minutes unmasked or masked in under 6 feet. And I recommend that you have a kit. Everybody should have a kit. Everybody for the rest of the winter needs to have a kit, and the kit should include an oximeter because measuring your oxygen is incredibly important to knowing if you're going downhill, and a thermometer. I actually like the thermometers that are Bluetooth, so you can take your temperature, and if you've set up your account, you know your password, it'll show up on the internet and your kids can follow you, or you can follow your kids. And you want to have the medicines that make you feel better when you have a cold or flu, you know, throat lozenges, Tylenol, PM, whatever it is that rocks your boat when you have a cold or flu, Motrin, have that too. But oximeter and thermometer are the most important things. If you're negative after a real exposure, and you should look and see if you've tested too early and consider getting tested again. What to do if you're exposed, you consider yourself potentially contagious. You do, as I say, go get tested after day 5, and you go home for 14 days because you're in quarantine. You don't need to tell your contacts. You don't need to freak out Aunt Petunia yet, but you might have to. And again, have a kit. You want to know your oxygen. You want to know your temperature. So when to get tested, I think I've said it enough. You know now, okay? Now when to get tested overall. Days 5 to 7 after exposure, I said that, you got it. when symptomatic, go get tested. Call your doctor, find out where you can go. Now, I will say that it's getting harder and harder to get tested in the next couple months. It's going to be really hard, but you want to try to get tested because you want to know. You want to know what you want to know. You have to tell your primary contacts, and you want to know because you want to know what to do about the vaccine. You want to know because you don't want to, trust me, you don't want to tell your doctor forever. I think I had it in July. It's like, did you have it or did you not? It's good to know. All right, if you're going to travel, my recommendation is that you get tested that's in an interval that is primarily dictated by your turnaround time. You don't want to get tested on Thursday for a trip that you take on Friday and you don't get the results till Saturday, right? If you're going to fly on Friday, you should get tested, and they have a 24-hour turnaround time, then you should get tested on Wednesday. So you have time to get the results. You can't always have control of that, but I mean, the worst possible thing you can do is get tested and find out on the plane, right? You don't want to do that. So the most important thing is to have it as close to your trip as possible, but acknowledging what their turnaround time is. I also recommend that when you come back from a trip, you get tested 5 to 7 days after travel. And I recommend thinking about it like a pregnancy test. It's only good at 1 day in time. It's only good for that moment. It's not, oh, I was negative last week, so I'm negative this week. I mean, try telling that to your husband. Honey, I wasn't pregnant last week, so I'm not pregnant this week. Maybe not. Where to get tested? My favorite currently is the Stop the Spread sites. The Massachusetts Commonwealth has set up about 15 sites in mostly underserved areas, and they'll take anybody there. You have to say you're a Massachusetts resident. So if your Aunt Petunia comes from some other state, give her, well, I'm not going to say to lie, but they treat all Massachusetts residents. It's free, it's confidential. They've been doing it for weeks and months. They're really good at it. I went to East Boston, in and out in 5 minutes. I went to some other one, I forget which one, in and out in 2 minutes. They got it down. Their hours vary. You got to call, you got to make a reservation. It's not, whatever. It's not that easy. You can do commercial labs and urgent care centers. They're not free. They're not confidential. All of them are filling up. All of them are filling up. And the commercial ones are even offering, 10% off. They're commercial profit-based places, but whatever. But they are filling up. I mean, I talked to a lab place that said last week they were 30%, 2 weeks ago, they were 30% full, and now they're like 110% full. So plan ahead. If you're in another state, most states have free testing too. You just look it up, or you can just go to the hhs.gov website, put in your zip code, and they'll tell you where to go. So just a little bit on more on how to stay what I call safer. And the only way to be completely safe, we already know how to be completely safe. We stay home, we eat our lean cuisine in the basement, we don't go out, we don't buy groceries. That's how you stay safest, right? No contact, total shelter in place. Obviously that's not sustainable. So my goal is to find ways to be able to tell you guys how to stay safer, all right? The most important thing to think about nowadays is that all of us have different degrees of being safe. And when we say that we have a bubble now, we have to remember that the bubble that you think you have is a question of how many bubbles are around it and how many ways the Venn diagram continues to expand. Because, the cousin or cleaning lady or neighbor who seems like they're acting completely safe may be interacting with people who are not acting completely safe, and they're carrying COVID. So this is what we say about your lives. The bubble you think you have is actually, this is actually the bubble that you're really living in. At work, we say the bubble that you think you're in at the break room is actually influenced by the families and the bubbles of all the people that you're sitting there eating with in the break room, and they may well have gotten COVID. This is a fantastic set of graphs that show what a study in Spain showed if you have one infected person at dinner. And this kind of sums up everything that I've been trying to say. Now, first off, all these people are unmasked. Badness. That's badness right there. So when in this study, if 6 people got together in a private home, one of whom was infected, which accounts for 31% of all their outbreaks, and they say that it's higher than that here. Now it's more than half our social gatherings. If you're there together for 4 hours without safety measures, you can be pretty sure that everybody is going to get it. One infected person for 4 hours with no safety measures is probably going to give it to everybody if they're in their high infectivity point. If you use face masks only for 4 hours, you're probably going to only protect one person from getting it, but you will protect that person. This is overall averages. If you open the windows and you reduce the length of time by a couple of hours, you will probably just have one person get it in this study. Now, this isn't something that I want to say, you know, okay, hold your Thanksgiving with 80 people, just keep the windows open and only have it be for 2 hours. But it just shows you that there are things that you can do to make it safer, and there are absolutely things that you can do that make it extremely unsafe if you happen to have somebody there that has COVID. And why do you want to do this? Well, first off, because we want to learn from history. The pandemic in 1918 had a bad, you can see back in June and July, they had a bad surge. It was devastating. And this was a devastating disease. People died in 12 hours and they died horribly, visibly. It was terrible. Very scary. And people were very frightened and people stayed home and things got better. And then look what happened in the fall and look at what we're looking at. Look at what happened in Canada. They had an October Thanksgiving and now their numbers have skyrocketed 4 weeks later. The same thing is going to happen with us. If we can't hold it together in Thanksgiving, 4 weeks later is Christmas Eve. And that's when people are going to start being hospitalized again. And we're going to start seeing this kind of spiral in the deaths. The other thing that you need to think about very carefully is who in your family is at risk, not just who might bring COVID in, but who in your family is at risk. And we know who these people are. We know who's at highest risk. It's people who are older. And we don't have a definition for older because every decade gets worse. So from 45 to 55 has some level of risk, up to 65 more, up to 75 more, and then of course past 80 is much higher. It's not inevitable death, but it's a much higher death rate. So anybody who is older, anybody who has serious other diseases, heart, kidney, lung, diabetes type 2, organ transplantation, and cancer. All of those people are at higher risk. Now the cancer, we haven't teased out every single thing, like if you have cancer, if you had cancer 5 years ago, but you're fine, is that higher risk? We don't know. If you have cancer that is that seems to be in remission right now, are you at super higher risk? We don't know. What we do know is that cancer as a whole and active treatment so far is looking like it's a higher risk situation. And we need to keep those people in mind. Certainly anybody with active treatment, certainly if it's immunotherapy or chemotherapy is at higher risk, not necessarily to get COVID, although they may be if they're immunosuppressed, but to have complications, to end up in the hospital and to die of it. The other thing is the guilt. I just cannot begin to tell you how devastating the guilt of bringing COVID into a family is. And it's usually a lot of the time, more and more you can't figure out where you got it, but a lot of the times people know exactly who they got it from. You know, they got it from Uncle Maskless. They got it from the poor cousin that has to work at the group home. You know, they know where they got it. And the guilt just for disrupting people's lives, if not for causing incredible illness and misery or hospitalization or even worse, is just terrible. And it's just, I'm just telling you, I've talked to a million patients, it's not worth it. Just want to talk about college kids for a minute because I know this is a huge issue for a lot of us. I think what you need to do with college kids is you need to have a very serious discussion with them before you bring them home. And that it shouldn't be automatic, oh, it's Thanksgiving, it's their first year, of course we're going to bring them home. I think there's situations in which it's safe enough, it's safer, and there's other situations in which it really isn't. Certainly it's influenced by the college. If the college says the kids can't go home, done. If the kid said if the college says the kids have to leave and they can't come back, done. But for all the others that are in the middle, I think a huge question to ask is how complex is travel? You know, if a kid can just, come with a friend that they've been bubbled with in a car and get here, with a couple-hour drive, no big deal. If they have to take, 2 planes and 2 trains and an automobile, more opportunities for exposure. Super important question, not that getting increasingly irrelevant, but the rates of community transmission. In September, we were having horrible outbursts in Texas, and I'd be really nervous about a kid coming up from Texas. But it was really low here. I wasn't so nervous. So you really need to think about that. What's the rate of transmission? What's the rate of disease in the schools, towns that they come from, and ours. Also, how safe have they been? How safe have our darling children been? Some have been spectacular. I'm so admirable of a lot of these kids, but some have to work in restaurants and have a large bubble and are still maybe going to parties. How tested have they been? Because I think testing, first off, it's reassuring, but also it creates a culture of being careful. So if that's a question to talk to them about. And then the other thing is to talk to them about what their priorities are upon their return. If their number one priority is to see every one of their high school friends when they come back, that's an issue, because that really expands your bubble. But if their primary, all they want to do is come back and spend time with grandma, that's a different set of priorities. So I think you need to talk to them about that. If they're going to come home, I think you should try to test as close as possible prior to travel, just like we discussed, based on the turnaround time. And then you should have them come home and quarantine as long as they possibly can. And if they can't, you should mask them. My kids come to my house, we're all masked all the time. We're all more than, like 12 feet apart from each other all the time. They don't live with me, but that's when I did. I had one lived downstairs, one lived upstairs. We were masked when we were on the same floor. It's not that hard. We're all getting used to it. And then I would test them day 5 to 7, and they should absolutely 1,000% have masks around elders. Okay, so bottom line is, what do I think we should do with Thanksgiving? Well, in October, I wrote an essay about should I have Thanksgiving in COVID. And then over the last few weeks, the community transmission has started to spiral so far out of control that even a week later, I had written a thing that said, basically, stay home. I really think we should all just give it up for 2020 and make ourselves stay as safe as we possibly can, so that next year, everybody's at our table. And it's easier for me to say this now too, because of the excellent news about the vaccines. I mean, I think it's quite possible that next year's Thanksgiving is going to be the exact kind of tradition that we want to have. And we want to be able to look back, just like they did in World War II, right? In World War II, they couldn't get nylons or turkeys or whatever, and they had really scaled down Thanksgivings. And then our grandparents talked about that. Yeah, we couldn't have that good of a Thanksgiving in 1942. That's what we want to do. We want to be able to say, no, we skipped it in 2020, but look at us now, even when our moms drive us crazy. We need to have grace on both sides of this. That's basically the bottom line. So I'm happy to take any questions if I haven't run too far over. And I really, again, appreciate the opportunity. You guys were great to listen to me help keep us all safer.
Wow. Thank you. That was great, Robin. Thank you so much. We do have a couple of questions. So if you're okay with it, I can get started.
Yeah.
So we have a question from Charlotte. Is a 14-day serious quarantine the most important thing for grown children coming in? There is no airline travel or need to stop during the drive to us. Should they also be tested?
I think testing them right before they come as much as you can, and day 7 is a very powerful thing. That means that the whole week that they've been with you, they have not been, if they're negative, they haven't been contagious. Going for another 7 days of full quarantine is what's recommended by the CDC. So the CDC is still recommending 14 full days as of yesterday.
All right. We have some questions from Meg. Should we worry about surfaces, mail, delivery boxes, and bags?
No.
We'll be Christmas shopping soon. You did talk about that, yeah. One more from Meg. Can you get reinfected? Is it okay to be near someone who has had it before?
Yes, you can be reinfected. We don't know how often.
And is it okay to be close to someone who has had it before?
That, well, if you know they're negative.
Okay.
But this is part of what I call building the plane while we fly it, right? You really don't have enough data on reinfection. And it can certainly happen with other viruses. And we've seen a few documented cases, like I think there's been like at this point 5, where they've tested the genomes. They're absolutely positive the person was reinfected by a different, a second time. Now that's out of, millions of cases. So we know that it can happen with this one. We know that it can happen with other viruses. So there's no reason to think that it can't happen to us. How often and of what severity, we don't know. Most of the second cases have been milder, but not all. In fact, I believe there's been 1 death from a second infection. So I think we'll be able to say next year what to do, but for now I would play it safe.
So my question was, for people who've had it before, that's not a license to not wear your mask.
Nope, not yet.
Okay, great.
Or people that have positive antibodies, which I didn't get into, but you still can't change your behavior.
Yeah.
The next one is from one of our board members, and Rerick. Can 2 couples who have been isolating since March and who have agreed to be on a porch with open windows and eat at least 6 feet apart share the experience of eating together?
It sounds like the safer-est way you can do it.
Okay, great. Oh, good. And so you have the green light.
It's not 100% safe, but it is as safer as you can do it.
All right. The next one.
Space heaters.
The next one is from Paul Wexelblatt. With an oximeter, what value of oxygen saturation should be concerning?
A trend downwards is concerning, more than an absolute number. These oximeters, they're not 100% reliable. So I would never want to say, oh, at 93, you need to panic. But if it has always been 96 and now it's 93 and then now it's 92, then I think you need to call your doctor.
And where do you get these? Is it just like at a CVS?
Yeah, they're there.
All right. The next one is
I even hear that Apple Watches have them, although I haven't found it. I think it's a beta product.
Oh, I didn't know that. The next one is from Vanessa. My daughter's college pals are getting off the plane from all around the country. We have asked her not to see them for 2 weeks. They're getting tested after arriving home and are declaring that they're COVID-free. Should we have our daughter tested in the next weeks, assuming she might be seeing her friends on the sly?
I would have that girl wear a mask all the time.
All the time?
Yeah. If you think the kids are going to sneak out, I mean, frankly, I haven't seen much of that, but if you think that compliance is going to be an issue, then I would definitely ask for a mask all the time. Yeah, I mean, if they're going to go out with other people, they need to wear a mask when they come back in the house. Testing would be, as I outlined, shortly before arrival, 7 days after arrival.
And then should Vanessa's daughter get tested, the one who would be seeing her friends who have been traveling?
Yes.
Okay.
Yes.
We have a question from Joan. What are your thoughts about takeouts from restaurants? How safe is the food?
There's been no documented incidences of transmission from food, and it doesn't make theoretical sense. If it's going to go down your mouth, it's going to go into your stomach, where your stomach acid's going to kill the virus. From a theoretical standpoint, the takeout containers, you have to think about, did the guy cough around his mask and touch the surface that you touched? And I mean, I think it's very unlikely that you could get COVID from any container. But it's not impossible. It's not 1,000% impossible. I'm not worried about the food.
Okay, so when we get the food from outside, should we be wiping the containers before we put it on our dining tables, or?
I think you should wash your hands.
Okay. The next one we have is from Steffi. With respect to vaccines, they seem to vary. And so should we be looking for one of them versus another?
I don't think, I mean, we don't have enough information yet. Each of them has been studied on less than 100 people. or reported on them. You know, soon there'll be thousands, and by the time non-healthcare workers have access to them, they will have been tested on tens of thousands. So I think it's going to come down to eventual data and logistics. You know, the Pfizer one has to be, you know, super frozen, and that's going to be complex in many areas, including rural areas. You know, some Johnson & Johnson's is probably, if it gets approved, it's probably only going to have one shot, you know, so maybe you want to wait until you can get one shot instead of two. You have to get two of the exact same ones, you know, that'll be tricky. I mean, you know how much trouble we have getting the shingles shot. I don't think we'll have that much trouble with these, but the bottom line is, so obviously I can go on and on and on about COVID, but I think it will become clear over time which of these multiple vaccines. I don't think we're only going to just have, you know, one or two choices. I think we're going to have like 7 choices, 5 maybe.
Wow. So just following up on the vaccine, Steffi has another one. So will the efficacy of the vaccines, will they be similar?
Data to come.
Okay.
More details to come.
All right. The next one is from Diane. What is the situation for a teacher? My kid is a teacher, and I've been seeing her with the mask 90% of the time. She's getting tested about every week. Is it okay to keep seeing her? Meg, I think this applies to you as well.
Yeah.
Well, if we are no longer seeing my daughter, who is a teacher, in person, just because it's our responsibility and her responsibility to keep everyone in our community safe. As Robin said, there's our pod, but then the pod spreads by whom, you know, who those people are seeing.
Right. I think unless you can say to yourself that you're going to see them always with masks, mostly outside, most entirely distanced, you know, with great hand washing and as good a ventilation as you possibly can, then it may be a riskier business. But I'm certainly seeing healthcare workers and teachers myself walking. You know, I walk with them, and we're very meticulous about distance, and we're meticulous about masks.
See, I'm a baby. I don't like the cold.
Yeah, this morning was not a pretty picture.
That's true.
Yeah, I wore pretty much everything I owned to see that woman.
Vanessa has another question, and this is actually about you. She's wondering how, Robin, you and your colleagues are doing, and how are the cancer patients doing? Has there been an interruption or delay of cancer care for these patients?
Not care. We did a good job of taking care of people particularly during the surge, and we will continue to do that because the priority is to keep the care. We are going to see a terrible impact in terms of delayed diagnosis. Without question, that's going to happen. I mean, for the rest of our lives, we'll see graphs of colon cancer diagnoses, and we'll see a decrease, and then we'll see an uptick.
It's 7 o'clock.
It's 7 o'clock.
Sorry, that's my computer.
Okay. Okay. So anyway, you know, tragically, unfortunately, the viciousness of the first surge will end up resulting in people not going for preventative care and even symptomatic care and staying home. And that's going to result in more advanced disease. As far as how doctors are going, I think doctors, nurses, healthcare workers, respiratory therapists, janitors, everybody, I think we're absolutely exhausted. I'm not on the front line, so don't let me, you know, my we is my colleagues and my loved ones. But I think they are absolutely exhausted. They're incredibly discouraged. I mean, can you imagine spending 8 or 12 hours in full PPE, watching one tragedy after another, and then going out and seeing, you know, bars full of people? I think whatever frustrations we feel about a lack of central leadership or an inadequate response to the pandemic is magnified about 500 times by people who are on the front lines. It's devastating, devastating. Be Kind to a Health Worker week, month, season.
Robin, we are so grateful to you and all of the providers out there on the front lines, and the researchers and the scientists, and you sharing this with the community to keep us on our toes. Our hearts go out to you. Our gratitude is deep and wide. So thank you so much. We may not have gotten to everyone's questions, but I want to make sure to let you go so that you can rest and take good care of yourself. And I wish for everyone, we're getting lots of thank you, Dr. Schoenthalers, in the message field over here. They say that your talk was so wonderful, and it was. So I hope the next time that we see each other and chat that we will have a subject different than COVID, or maybe we will have a subject that says we're getting on the other side of it. So do take care of yourselves. Enjoy your chicken, your turkey, your peanut butter and jelly sandwich, if that's what you're going to do.
Lean cuisine.
Yeah, lean cuisine. And I just have to say, I love the peeing slide. Best slide.
Well, good. Maybe you like this one too. Let's see. There you go. So, not that I want to advocate, but I think we've all earned a lot of self-kindness, and we'll earn it, we'll deserve it after this, but it's just 1 year. It's just 1 year.
That is
And
true.
we all want to be able to look back with no regrets, and knowing that we did our part to try to get a handle on this.
Yeah.
Well,
Four
thank
weeks
you again.
4 weeks from Thanksgiving is Christmas Eve. Don't let our people be in the hospital.
Zoom with your friends, folks. All
Okay.
right.
All
Thank
right.
you
Thank
so
you again. And thank you to all the attendees.
Yeah.
Thanks so
Thank
much for coming. Really great of you guys to do this. Thank you.
you.
Thank
Take
you.
care.
Stay safe, everyone.